No, no captions.
All right. Okay.
Okay. So let me have you spell your first and last name.
So I'm Mikhail Kogan, spelled Mikhail. Last name is Kogan, Kog as George, An as Nancy. I'm associate professor of medicine at GW in Department of Geriatrics, Palliative Care, and Integrative Medicine. I'm also medical director of GW Center for Integrative Medicine. That's where we have our long COVID program. It used to be part at university, and then grant finished, and these patients require so much time. Insurance don't cover costs enough, so we moved the practice over to the CIM, Center for Integrative Medicine. So
Got it. So tell me a little bit about what the Long COVID Center is, what you do,
yeah,
how long it's been around.
yeah. So the whole problem has been only around for a couple of years, so everything is fresh here. The clinic has been around since '98. It's academically associated with university. In fact, it was part of GW University. Now it's a standalone business. And at this point, we have a few hundred patients there in a program. And the big pieces of long COVID, there's a team of several practitioners that includes more of a standard approach, medications, and then also kind of a more of an integrative approach. So for example, acupuncture and acupressure we use for a lot of our patients, and we can talk about that more. And then we also have a very effective twice a week virtual support group, and that seems to be the most important aspect. These patients have so many symptoms, so many questions. So running this support group that ranges from maybe 6-7 patients to 20 patients on any given day is kind of the most important aspect of it. We found that in that program, we can, for example, this past week, we talked just about this article in the program. That's all. 2 hours were spent covering the whole study because it's that important. So we basically try to stay very up to date. We try to kind of find the treatment methods that are up and coming. Part of it because there is really no standard of care for this, since all of this is so new.
So when I read this article, it kind of piqued my interest. So I'm like, serotonin. Okay, this is people in other kind of mental health issues take this.
Mm-hmm.
I was thinking, maybe this could be something. So tell me, you read the article.
Yeah.
What do you think?
Yeah, well, so it's one of those key articles that occur in any field that's going to be kind of a paradigm shift. So it's that important. But interestingly, I think the conclusions of the article is what everybody gets wrong. Everybody thinks that, serotonin, so everybody's going to take antidepressants, completely missing the point. So antidepressants is going to do nothing here, and I can explain in detail why. The value of the article is, in fact, that saying, look, chronic inflammation, clotting, ends up driving serotonin down. When the serotonin goes down, this is what triggering all of the depressive anxiety symptoms, but also the most important one, which is the autonomic instability, what we call POTS, or postural orthostatic hypotension syndrome. Problem with that is basically patients get weak, they change position, they get dizzy, they get lightheaded, they try to walk, they get short of breath, they can pass out. That is one of the most problematic components of this disease. If you look at past some of this other viruses, like let's say chronic mononucleosis or other diseases that are sort of in that category of post-infectious etiology, like chronic Lyme, people get that a lot less. So they're just not as sick. I mean, they still have a lot of fatigue, and they have a lot of joint pain, and they have a lot of intestinal problems, but they don't get this overwhelming concern of I can't walk because I'm dizzy or I'm weak and I'm lightheaded. So the serotonin seems to have a critical role there by basically mediating the vagal response. So the vagus nerve is the nerve that kind of connects everything. So think of this as, so we have the central machinery that sends the signals, the brain, right? Central nervous system. And then everything gets transmitted to periphery. And the in between, you have this vagal nerve that tends to regulate it all. And serotonin is kind of this molecule of regulation in there, if you will. Not the only one, that's more complex than that, but that's what these researchers found. They found that it appears that autonomic dysregulation in big part is due to the serotonergic dysregulation, and they described how this happens. So that's the fundamental breakthrough here is that in the past, everybody knew, okay, well, it's autonomic dysregulation. Okay, now what? What do we do with this? Well, now we know how it happens. So we think that we will figure something out here. And one of the key signaling pathways that they described is not just that serotonin is low, but how it happens. For example, that tryptophan doesn't get effectively moved towards being a serotonin. So tryptophan is, everybody knows, right? On Thanksgiving, you eat a lot of turkey, you're in a serotonergic coma after too much tryptophan. So bottom line, for whatever reason, in long COVID patients, tryptophan doesn't easily become serotonin. Why? They put the whole complex scientific explanation. I don't think it's all that essential to try to be precise. But bottom line, it does give us at least one therapeutic venue to say, look, why won't we give people more tryptophan or this molecule called 5-HTP, which is the kind of a precursor to serotonin, but it's not the tryptophan. The tryptophan converts to 5-HTP, but very slowly. It's the time limiting step. So you need some cofactors like B6 vitamin, B12, and others to convert. But 5-HTP can be a faster conversion. So they basically gave us all this flow right off the bat to say, let's, we could try that already with our patients. The problem with antidepressants is SSRIs, what we call serotonin, selective serotonin reuptake inhibitors. They block reuptake of serotonin. They don't make more serotonin. They make more serotonin available. And the question here is because most of this dysregulation occurs peripherally, and the SSRIs work primarily centrally. We don't really see in clinic. I mean, look, we have 2/3 of our patients probably with long COVID on some kind of SSRI already, and they're not any better. In fact, it doesn't do anything. I mean, we give it to them because they're very depressed, they're anxious, they're sleeping often poorly. So we try them just like we would try in any other situation, but we don't see anything. I mean, moreover, I think we're seeing more side effects in this population than in other patients. Maybe that's because they're already kind of unstable partially autonomically, and so you give them more drugs, you can only cause more problems. But we've been giving patients generally more protein, and that's what seemed to work. So now I'm kind of questioning, well, could this be that just giving them more protein works because they get more tryptophan? Because that's what tryptophan is, just amino acid in food. So
interesting. Okay, so this is really interesting because I read this and I saw, oh, serotonin levels are low. Let's go ahead and write a prescription for serotonin, which is a generic medication, pretty cheap. Seems like an easy fix.
Exactly.
But it's not that easy.
Yeah. Well, I mean, we'll have to test the idea. I think it's one thing that what we're observing with few hundred patients is completely different when you're actually doing a quality randomized control trial. I have no doubt that that's coming. Just looking at how they've kind of positioned the whole study, it's pretty obvious that the next research step should be skip even the animal model, just go straight to humans. And we're talking about 18 million Americans suffering from this, right? So this is not this is like large percent of adult population. And in some point, the estimates were that 20% of everybody will end up with long COVID, those who had COVID, which is most population. It's a lot better now. So I think it's maybe maximum 5%. But think of this, we're all going to get COVID, just a matter of time. So if 5% of us continuously per year or something, are going to start getting COVID, we're looking at, we need solutions here. And interestingly, it's very hard to predict who's going to do poorly. So what I'm actually thinking, another huge point out of this study, we'll figure out some models of prediction. That's what's really missing. What's really missing is, let's say I have 10 patients who get COVID, right? Which is kind of roughly what we're getting now per week in our practice, just general statistics. So what I don't know, which of those 10 patients I should be like, you coming in every day, you're going to get this and this and that, and we're going to treat what, or whom I can just say, okay, take your Paxlovid, take your vitamin C or whatever else you want, and just call me back in 3 months. And we have no idea. We have no way of judging who's going to get this long COVID and who will not. We sometimes can have a sense, like if the patient was already sick to begin with, let's say they have some chronic fatigue or they had some other chronic infection in the past, they're at high risk. But it's very difficult to predict beyond certain simple things. If I have same 50-year-old healthy woman, why is one person gets the long COVID and the other doesn't? So this gives us, this particular study gives us the possible venue into saying, look, maybe we are measuring serotonin, maybe we're not. But at least it's a very big step in the forward, saying, okay, if we can predict that this person is going to drop serotonin, they're going to drop serotonin quickly, okay, then maybe we'll have a test. Interestingly, serotonin currently is not used in any way, shape, or form clinically. Like, we don't just draw blood on people in the clinic to say, okay, you have low serotonin, we're going to give you SSRI. It just doesn't work that way. There has been some work done where you look at urine metabolites of serotonin. We don't do that anymore. There are some clinics that do that. I'm not opposing that, but I have not seen any really good results doing that. So we kind of stopped as a whole clinic, but definitely it's there. But
So,
question, yeah.
oh, yeah, question. So if the answer, I guess, to a lot of people's question of, does this study mean I just need to be on serotonin or increased level if some of your patients are already on it?
Mm-hmm.
Does it, and you say it has to do with the tryptophan, is that a way, is there like a pill, or, people think turkey,
No,
but
yeah, no, literally, you can eat more protein, which is definitely something I would recommend to every single long COVID and post-COVID patient for a couple of months. Just significantly boost protein intake. Just because not only because of the serotonin, but you need other things. I mean, when you recover, the body tends to rebuild lots of things, not just serotonin, but certain other structural components. You also tend to be, especially when COVID hits for a while, let's say like for a week or two, you may not be moving enough. So you may lose some muscle strength right away, especially if somebody's over 65, they're going to lose muscle strength and muscle mass very quickly within days. So just extra protein is good. If you really want to take just an extra tryptophan, you can just buy the tryptophan as a powder or very inexpensive capsules. But again, I prefer 5-HTP. It's 5-hydroxytryptophan, so it's a modified form of tryptophan. It's a bit more active, it's easier to take, it's a bit more expensive too. So tryptophan is cheaper, but not everybody's going to effectively convert tryptophan to serotonin. There are some conditions where you need a lot of cofactors. And that gets a little too complicated for the interview, but in essence, there's a bunch of other vitamins, like B vitamins and some minerals, magnesium, for example. Magnesium is a critical cofactor for some of this conversion.
and would you recommend, if somebody is hearing this and they say, oh, these are things I can buy over the counter, do you recommend that they do it on their own, or do you recommend that they see a doctor to kind of oversee this stuff?
That's a great question. Generally, just because we don't know enough yet, I would say work with someone who understands this a little bit, partially because generally, I mean, tryptophan is going to be relatively safe. The bigger problem is not that. If you're going to eat more food, I don't have a problem. But if you're going to start buying supplements, you have to know what you're buying because, right, it's a completely non-FDA regulated field. And you can end up buying products that either have nothing in them or, God forbid, have some toxins in them. I don't recommend people just buying things off without being carefully guided by someone. And it doesn't have to be a doctor. So that's one important point. We don't need physicians to do all this, right? I mean, we're talking about basic biochemistry that all nutritionists do, all kinds of holistic providers, naturopathic doctors, coaches of all kinds, and a lot of people, they study this for a living. I mean, and that's what they do. In fact, I would say probably most physicians don't even know how serotonin gets made, all the cofactors that are needed, just because that's not what we do. I mean, we tend to deal with much more severe acute illnesses, and that's what we do. I mean, the recovery from long COVID, in essence, currently is a bit of a mystery, right? So there are a lot of people who are saying to us that they found solutions going to acupuncturist or going to a chiropractor and fixing their mechanical problems instead of any kind of pills that they simply just did some body work. So bottom line, I think a lot of systems affected, and the medicine has only some answers. And currently, because there's no formal anything, in essence, people find their own way to get better or not. I mean, there's a lot of people who are still really sick. I mean, we have some percent of the patients who got original long COVID from the first strain, and some of them are still like miserable. They're basically on disability, unable to walk, many in the wheelchairs, and why are they not getting better?
We have somebody, a photographer at my station, who got a very mild case of COVID, just kind of stayed in his basement for a couple of weeks. And it's been 2.5 years. He still can't smell anything. He can't exercise. He gets very fatigued. And then that's impacting his mental health as well. And I heard when you said that kind of the group therapy kind of helps. Is that for the mental health aspect of it?
That too, right? Because we do some mindfulness practices in that group. We do some kind of a positive reinforcing and positive reintegration therapies. So we do lots of things that try to sort of go just beyond simply, okay, we're going to experiment with tryptophan or something. Like it's much more holistic in the way. So the other really interesting thing in the study, I want to make sure we don't forget, it also explains what happens on a cognitive level, because a lot of the patients, so first most common struggle is just general fatigue. People just like, they're so fatigued that they can't even walk a couple of blocks. Second biggest things, it's not actually shortness of breath. I think shortness of breath is probably third, at least in our population, but it's the cognitive problems. It's not even mental. It's not even depression and anxiety, but it's really cognitive. They really struggle. And some of the patients who especially were very cognitively engaged before, like lawyers, physicians, scientists, I mean, they're even 20-30% drop of cognitive capacity is a major problem, right? Because they can't do their job anymore. And so we see this a lot. And I think the studies also points towards possible explanation. The serotonin does play a role there too in the signaling and in the workings of how we retrieve memory, particularly in the area of the brain called hippocampus. And we occasionally would even get an MRI with specific analysis called neuroquant, which shows us the brain volumes. And we see that after COVID, the hippocampus gets smaller in a lot of
Could the cognition come back if they lost it, do you think, with this study maybe learning?
Well, yeah, that's the hope. Some people get better. Yeah, we definitely had people whose cognitive impairment completely resolved. And yet we still have some people who just as bad as when they came to us. So again, is it because those people, we couldn't get their serotonin back up? Maybe. I mean, but that's I think that's what the study is so good. It gives us a new direction to explore. And trust me, we spend 2 hours talking to our group about all this, and they're like, okay, so I'm gonna go home and try tryptophan now. And somebody else, no, give me 5 HTP pills. So it'll be I say next few months we'll have some answers. And I'm sure there's gonna be studies.
Yes. So you say, people could eat more protein. When I think of protein, I think of animal meat. For people who are vegetarian or vegan who have long COVID, well, I guess what do you direct them to do?
Yeah,
what would you?
Good one. That's such a good one. I mean, the tryptophan is not so easy to come by in the plant kingdom. Probably mushrooms have some tryptophan. But there are some foods that are higher, like chocolate, I think is very high in tryptophan. There are certain foods. So I haven't done my homework right now. I'm not a nutritionist. So I can't come up with top of my head what turkey, everybody knows turkey, right? But yeah, so you will need to be a bit more careful. You'll need to be more specific. I don't think it's a problem. I believe, let's actually spend a second and look up. It's just that easy. Tryptophan. High foods. Let's see. Yeah, so actually, so chicken, eggs, cheese, fish, peanuts, pumpkin, and sesame seeds, milk, and turkey. So seeds would probably be then my choice for those who are vegetarian and vegan. So yeah, tryptophan is not an essential amino acid. That's an important point.
Okay. So for people who hear this and they say, okay, I'm going to increase my amount of tryptophan that I consume, is that going to make me tired? Is that going to be a side effect of this?
Well, I mean, I think the tryptophan coma, as we describe it, has nothing to do with the just amount of tryptophan. Is a bit more complicated. But yeah, I mean, no, you don't have to worry about that. I think if you target this as eat a bit more tryptophan-rich foods with every meal, that should be the key. So we constantly make serotonin and we constantly break it, right? So it's a continuous process. You can't just say, okay, I'm going to have bunch of peanuts with the dinner and that's good enough. No. You have to, throughout the entire day, preferably every meal and every snack would have some protein in it to kind of support your continuous production, because the system does it all the time continuously.
And I know you have to go soon. So
Yeah.
if we consume the tryptophan through our meals, that helps with serotonin production. Am I getting that right?
Pretty much, you're getting it right. Yeah. And then the other thing I would definitely do, like if somebody wants to do things over the counter, I would take a very high quality B vitamins as a complex, like what's called a B complex, and some magnesium, because those are the things that really critical for the conversion of tryptophan to serotonin. Magnesium probably doesn't even matter what quality you get. It's also a pretty simple element. So I would say anybody can get it. Glycinate would probably be my preference. Magnesium can upset stomach if you take too much. Glycinate is kind of the best. But if you're constipated, you can take citrate and actually can help the constipation. So we often use different forms of magnesium for different, like the malate for some pain syndromes, taurate for brain problems. So they're depending on a form to which magnesium attached, we target different organs.
Got it.
So
and you said the serotonin, the pills that people take, it doesn't increase, it just makes it more available, what you already have in your body?
Pretty much. So SSRIs, the antidepressants, they block the breakdown of serotonin. But the problem is if you don't make any, eventually you very quickly kind of get low on everything, on precursors and they stop working. And that's what we clinically observing. It's not as effective. Generally, antidepressants have a lot of problems. They're just not perfect pills. If you can get away by eating high tryptophan diet and get to the same place, there'll always be the choice eating better foods. I mean, it's self-explanatory, right? Medications are always going to have some side effects. The biggest concern with antidepressants, if you take some populations, like in older people, especially older people who are a little thin and maybe frail, you could have some really serious side effects, like low sodium, for example. So you have to be very careful. Like you cannot do this on your own versus, of course, you can just eat more tryptophan-rich foods and see how you feel. That would be perfectly fine without supervision. But the moment you start taking any supplements or medications, you need someone who understands how to guide you.
Got it. My last question for you, how many people do you have in your program right now, and are you still accepting new patients?
We are accepting new patients. We have a few hundred patients, but the kind of more of a regular core is a lot smaller. Probably have about 30 patients who come to all the groups. But those patients are kind of the sickest, and so we have we can take them. We have more space for the groups, but also for individual therapies. And our program is really kind of takes whatever is available, and we try not to worry about, well, what is the acupuncture? What is the evidence for acupuncture for long COVID? Well, there isn't any, except that if you're in China, everybody gets acupuncture because that's what they do there, right? So a lot of these things occur simply how certain places are practiced, and since we're fully integrated in that sense, we have 4 acupuncturists on staff, then we recommend it to everybody. And acupuncture is great because we can teach patients to do acupressure at home. So they'll do a couple of sessions of acupuncture, and then we'll show them how they're going to press their points, and they can do that 3, 4, 5 times a day. That seems to be one of the really big improvement points for this autonomic instability piece, at least, and also for pain. For fatigue, for some other symptoms, not so much. We still have so many things we have no answers for. So, but want to definitely say that this is a really important study. It's going to carry a very long-term future weight. A lot of it's going to be one of those studies that going to have thousands, if not tens of thousands of references. So everybody will be referencing this study going forward for their studies. That's for sure.
With all the studies that have come out, would you say this is the most significant?
For long COVID? I would say it's in top 3 most important long COVID studies that came out in the last 6 months. Yeah, for sure. Like I don't know, maybe it's the most important one. It kind of depends what you're looking at. I mean, there's been some really important studies, like for example, studies showing that yes, Paxlovid can decrease risk of long COVID. Like I would say that's really important because it gives you immediate therapeutic aspect. Problem with this study, we don't exactly know how it will truly translate to the therapy piece, right? I mean, you and I discussing all this, most of it is still a speculation because we haven't tested this. You have to test any of these ideas to say, okay, if you take tryptophan at this amount, this many times a day, your risk of, or your symptoms going to get better this way. Like, I have no idea. I mean, I'm just reading the study and trying to extrapolate just because I'm in the middle of figuring out what to do with dozens of our patients who are like, help me. And no, we don't want to wait for FDA approved anything because I'm suffering now. And so that's part of the problem. Then conclusion, one thing I will say though, I'm very upset with how government handling long COVID. It's basically not handling it. Grants are lacking. One of the big studies that was supporting assessment of physical therapy is completely poorly designed, doesn't have any value in my opinion, just wastes of millions of dollars. And yet the studies like this one show up just because the academicians are really putting an effort. I think government has to step up and say, here, there's a lot of money and you have to study this, because if I'm right, and we're going to have tens of millions of Americans suffering with this going forward for decades, it's a fiduciary responsibility of the government to say, okay, we're going to support this, our own constituents, because it's really going to get out of hand. I mean, we're going to lose a lot of working force if we do nothing. And it's interesting that nobody wants to, like, I'm not seeing a lot of anybody talking about this. It's only physicians yelling about it.
That's why I continually try to update on long COVID, because it seems like people want to pretend like it's not there, because
That's
unlike
exactly right.
someone breaking a leg where you can see them in a cast, long COVID, you can't really tell by looking at someone.
That's it. And often these patients look perfectly normal. Like they talk normal, they don't look tired, but beyond that facade, there are so many problems often. And they've suffered it sometimes for several years. They've kind of adapted to not appear sick. And that confuses the issue for a lot of people. They think like, oh, that person is fine. Just send him home or send him to psych. Like, a lot of the times what I see happens is the primary care field does not have time to deal with this. I mean, their visits are 10 minutes. These patients require an hour for each visit. There's not enough resources in the system. And so they basically get shuffled between different services left and right. That's not what the patients need. Patients need some kind of a communal support. They need kind of the coaching aspect of it, because a lot of the things, especially when we don't have a prescription to fix problems, right? They're going to gradually try different lifestyle approaches, but they need to be supported there. And, insurances don't pay for coaching, but they should be. Anyway, I can go on and get you tired.
Yeah, well, I really appreciate that. This has been good. For people who hear this, how do they pay for getting into your program, or how does that work?
So we charge $100 a month for unlimited number of sessions. So we try to keep it low cost. If they come to see us individually, we just have a fee for service. But often patients come one time just to check in, and after that they enroll into the program. It's gwcim.com, and we actually have a long COVID program is under there.
Okay, I'm going to link that on the story on the website so people can go ahead. Oh, thank you. I see it right there.
And I'll give you the actual link to the actual long COVID program. And we are kind of part of university. Originally, this was a grant to the university, but when the grant ran out, we took whoever could afford even $100 a month. We took them over to this. But there's still, like literally probably thousands of patients at GW who don't have a good care, mostly because they can't afford it. And insurances will only pay for like physician visit, right? But if they go to a nutritionist, nutrition consults are not covered by COVID, for COVID or long COVID. They're only covered
if they come to is there a nutritionist within your group?
Yeah, we have. That's why I say we have a whole team. And usually what we do, we give people super bills and they submit. And then we've had some successes. Like we actually had a small pilot project with Peace Corps, and we've made some of their patients better. And then the Peace Corps just paid us directly. We didn't charge.
Oh, okay.
So we have a capacity to do that, but we do that on an individual basis, just because we are so complex at how we see patients and how much time we put into each case. So we try to, sometimes we negotiate upfront contracts, like we can go to any insurance and try to negotiate. But it requires a lot of effort. So, and also a lot of the insurances just don't want to hear it. They're just like, nope, we're not talking about it. Just kind of very, very unfortunate.
Well, I really appreciate your time. This will be on tomorrow morning, and I will make sure that I will email you the link once it's online.
Sounds good. Thanks a lot.
Thank you so much. Have a good day. Bye.